Srisha Senthil, head of the glaucoma department, LV Prasad Institute, Hyderabad, one of the best glaucoma surgeons in India. And her lecture about the hypertensive phase post glaucoma drainage phases. Dr. Sarah, can you hear me?
Yeah, I can hear you. So you should allow me to share screen, please.
You can start, please.
Yeah, is the screen visible?
Yes.
Yeah.
Yes, you can start.
Thank you so much. Thank you, Mohammed Al-Hamri and the MN Ophthalmological Society for giving this opportunity. Today, I will be speaking about the incidence and management of hypertensive phase in glaucoma drainage devices. So hypertensive phase was defined long ago, was defined by Dr. Molteno after the insertion of glaucoma drainage devices. He observed that there was a tissue that was actually very thick fibrous tissue that was covering the implant, and this resulted in inadequate control of intraocular pressure. And he described the behavior of the intraocular pressure in phases. It's called hypertensive phase, a hypotensive phase followed by a hypertensive phase and a stable phase. So we are here discussing about hypertensive phase. What do you mean by hypertensive phase? A hypertensive phase occurs secondary to a bleb encapsulation. You see here, there's a huge elevated cystic bleb, and this is a part of the wound healing process post glaucoma drainage device. And this is something that we always explain to our patients and tell them that so usually by about third week onwards, the pressures can start going up, and when it goes up, it doesn't mean that it is failure of implant. It means that your body is reacting to a certain way when a drainage device is placed, and this is a part of the wound healing response. And I think this is very important to be able to let the patient understand. And usually it begins by about the first week for sometimes third week. I have seen it as early as 3 or 4 days post-operatively also. IOP gradually raises, and sometimes the intraocular pressure elevation can be even higher than the preoperative intraocular pressure. What is very important is one needs to understand that there is an elevated tense cystic bleb in the absence of a tube block. So tube block should definitely be ruled out. The other thing we need to rule out is a flat bleb. So which means that the bleb has to be elevated, tense and cystic. If you see, this is a picture of another patient where you can see that the bleb is flat. So you don't expect an AGV bleb to be flat that way. It is usually elevated and very cystic. If you see a flat bleb, it's possibly a bleb that is not functioning at all, not filtering at all. So we need to rule out these two. Tube block should be ruled out, flat bleb should be ruled out. Usually it is in the early postoperative period, low pressure followed by high pressure and associated with elevated cystic bleb. So why does this happen? We need to understand the physiology of the drainage implants. Whenever a drainage device is implanted, there is a fibrous capsule that forms around the plate. And remember, these fibroblasts cannot stick to any of the materials that we use for a drainage device. And this fluid that gets accumulated between the fibrous capsule on one side and the plate on the other side, it kind of gets sequestered inside. And this fluid, from that fluid pocket, passively diffuses out, and it is absorbed by the periocular capillaries and lymphatics. Sometimes if this fibrous capsule is extremely thick, then it does not allow the fluid to drain out very well, because of which the pressures can be very elevated. So usually because of the wound remodeling that happens in the late postoperative period, by about 4th to 6th week, usually the bleb tends to become a little less tense, and it allows more fluid to drain through, thereby decreasing the hydrostatic pressure inside the bleb area, and the pressures generally come down. So how does this behave in a valved implant versus a non-valved implant? We know that in a valved implant, it is more common to have a hypertensive phase. It is also seen much earlier. And in a non-valved implant, it is less common and is also seen much later after the ligature opens up. And when you take a histology of this blood wall, we realize that there is a fibrovascular tissue which is very thick. The outer layer contains of more of a vascular and inflammatory component, and the inner layer being a thick fibrous component. So this thick fibrovascular proliferation, remember, that can be very, very thick in a valved device. Sometimes the thickness of this, if you say cornea is about 500 microns thick on an average, the thickness can be as close to 475 microns with an AGV versus half of that in a non-valve device. So in a valve device, it is much more common and much thicker, because of which the fluid doesn't drain out very well. So now, why does this happen? What are the factors that affect the hypertensive phase, and what is the incidence of hypertensive phase in a valved versus non-valved implant? So there are certain risk factors that are known: higher preoperative intraocular pressure, prior anti-glaucoma surgery, myopia are risk factors, some of the patient-related risk factors, and it is more to do with the certain types of material that is used. For example, silicon devices possibly have little lesser compared to a polypropylene device. And also it's more common in those devices where there is an early aqueous outflow like that of an AGV compared to a non-valved device. Possibly there are situations, studies where people have looked at use of mitomycin. Will it help to decrease the hypertensive phase? At least in literature, the evidence that we have is controversial. There are a couple of studies which said that it helps, a couple of studies. In fact, a study from the Middle East actually has shown that it is detrimental rather than being helpful. And people also believe that use of steroids again can be helpful, or it could actually be counterproductive. On an average, studies have shown that the hypertensive phase can range from 40% to as high as 83% with that of an Ahmed glaucoma valved implant, while with a non-valved implant like the Molteno, the Bavelt, and the Adi, it could be as low as 27% or 16%. In our own studies that we have seen, the non-valved implant, the hypertensive phase was as high as close to about 20%. But not really that high that what we see in with AGV. What is also very important to understand is, how does this hypertensive phase resolve? So what do you mean by resolution? Resolution means the intraocular pressure should be lesser than what it was before the start of the hypertensive phase, or at least a 20% reduction in the intraocular pressure compared to the beginning of the hypertensive phase, and at least one or two medications less than what it was in hypertensive phase. So multiple definitions are used by people. But what we need to understand is, with that of an AGV, all eyes that develop an hypertensive phase do not resolve. Close to about 30% of these eyes continue to have elevated intraocular pressure, which means that these eyes are likely to fail in the future. So hypertensive phase, while with a non-valved implant like the Bavelt, what is very interesting is that the hypertensive phase, although in some studies have shown to be as high as 48 to 49%, all of them resolved with medical treatment. Of course, they do have little higher intraocular pressure compared to eyes with non-hypertensive phase, or those they require a little more number of anti-glaucoma medications. However, in those with valved implants, several of them, close to 30%, like I said, do not resolve, while in the non-valved implant, majority of them resolve. So this is a major reason. And why does this happen? This happens possibly because the fluid that drains into the subconjunctival space drains a little later, and the inflammatory aqueous that is supposed to be triggering this fibrovascular proliferation is less common in a non-valved implant in the immediate postoperative period. Is there a role of corticosteroids? Corticosteroids or NSAIDs sometimes may be helpful, and sometimes studies have shown that use of corticosteroids possibly decreases the inflammatory response and hence decreases the hypertensive phase. But this is a study that has actually compared the post-operative topical corticosteroid use with NSAID and shown that NSAID arm had less hypertensive phase compared to the arm where the topical dexamethasone was used. And also the mean intraocular pressure in the post-operative period at every post-operative visit was higher in the steroid, topical steroid group compared to the ketorolac group. So how do we prevent this? Like we said, one of the reasons why hypertensive phase develops is possibly because of the inflammatory aqueous reaching the subconjunctival space in the early postoperative period. So a thought is like a medical ligation. For example, you use topical aqueous suppressants in the early postoperative period, less amount of fluid goes into the subconjunctival space, and that possibly decreases the hypertensive phase, either the height of hypertensive phase or the incidence of hypertensive phase. And studies have shown that the hypertensive phase has, with topical aqueous suppressants in the early postoperative period, it decreases the rate by more than 50%. So 23% in a group with aqueous suppressants in the early phase, early postoperative period versus 66% when it was decided to start on anti-glaucoma medications based on the intraocular pressure. Also remember that the eyes that develop a hypertensive phase also resolve much faster in those with topical aqueous suppressants compared to the contralateral group. So it possibly helps to percolate the aqueous better with thinner and more delicate capsular wall that it forms because of less inflammatory mediators and thinner bleb walls. So what can be done with when hypertensive phase, fine, it is already developed now, the pressures are not coming down, you have tried everything, if medically it is controlled, it's fine, otherwise what else? So we can do a bleb needling the way we do for a trabeculectomy. So I usually do it on the nasal side because I believe that on the temporal side, it is, although the access may be slightly easier, the conjunctiva is on the thinner area, conjunctiva is slightly thinner, so I generally don't want to expose the area that I'm doing a needling or the entry part temporally. I prefer to actually do it a little bit superior and onto the nasal, onto the superior area, so that a large bleb forms in the superior area rather than becoming a huge, chemosed conjunctiva temporarily that can cause a Dellen and things like that. And I always try to close that opening with the help of a 10-0 nylon needle. Other thing that people also advocate, and sometimes we also do, is a bleb wall excision. You know that there is a thick fibrous wall that develops around it. So I generally excise a bleb wall, and when I do this, I excise it over the area of the valve, and that also gives me an opportunity to see if there's any kind of a fibrous tissue blocking the posterior exit of the valve area, where sometimes we can have a fibrovascular growth on the posterior aspect. So that is excised as well. The other thing that this is something that we have designed in our institute, where we have created a special blade where what I tend to do is I go and destroy the valve functionality by damaging the bimembrane valve there. So this one now behaves like a non-valved implant. So by doing a bleb wall excision along with the damaging the valve and do a ligature of the tube for a temporary one, like with an 8-0 vicryl or so, and also a couple of fenestrations in the front. So by about 4th week, when the ligature opens up, this actually behaves like a non-valved implant. We have published the experimental studies on this, and in the clinically, we have quite a number of patients that we are doing, and the results are very encouraging. So other things that we can do is to do a second implant, or to do a transscleral cyclophotocoagulation or an endocyclophotocoagulation. Sometimes we underestimate the usefulness of transscleral cyclophotocoagulation. We can do it for a temporary relief, especially when the pressures are extremely high. You know that this may take a little while for the pressures to come down, and you don't want to do another implant, especially in terms of children and things like that. I don't mind doing a limited transscleral cyclophotocoagulation. And once the pressures resolve, then I think once the height of the hypertensive phase or the raise in intraocular pressure comes down to some extent, generally they tend to fall in place, and medically they are controlled. So to summarize, bleb encapsulation is a part of postoperative wound healing. All of us should realize when it happens, why it happens, how we can prevent it, and how we can treat it both conservatively as well as surgically. This, to a great extent, can be prevented by certain intraoperative modifications. And like we discussed, early aqueous suppressants can be very helpful. So generally people ask me, how early do you start? I start as early as day 1 as well. So for me, the Bottom line is the intraocular pressure 6 and above? If the IOP is more than 6 even on day one, let's say 8, 9, whatever is on day one, then I don't mind starting them on aquasuppressants even on day one. And of course, I do give non-steroidal anti-inflammatory for a little longer, and I quickly tend to taper the topical steroids. Massage has shown some benefit, but I generally don't advise, because I'm very concerned that when they do the massage, sometimes you can have a tube corneal contact, and I'm averse to allowing the patient to do that. And like we discussed, when it is unresolved, we may need to go in for a surgical management of this hypertensive phases. Thank you so much for your attention.
Thank you, Doctor, for your sharing your experience. Any question? Thank you, Doctor. Thanks.
دكتور لحظة يا ما لكم هكذا كروت أستاذي can you hear us please Doctor can you hear us?
Yes.
Okay, thank you for your lecture. You didn't leave us any space for questions, because you already answered all our questions about this hypertensive phase. But can you tell me, you spoke about the factors affecting the hypertensive phase. Do you have factors to predict the hypertensive phase? You are familiar with the flow test. Flow test may predict hypertensive phase, or just case selection?
I think that's a very intelligent question. And I think there was one study that did talk about the flow test, and the higher the opening pressure, let's say if opening pressure is 18 and above, and these eyes are likely to develop a hypertensive phase compared to the opening pressure of 12 and less. In fact, we have published an article in IOVS way back in 2017 or 18. So what we have shown is that the opening pressure has got nothing to do with the way the stable phase pressures are. So sometimes you may require a lot of force, a lot of pressure to open it up, and sometimes it can go as high as 3,500 millimeters of mercury. We did that in the Ahmed glaucoma valve lab that we have in our institute. So the pressures can be as high as that, but once the priming is done and the bimembrane valves are opened up, the pressures, the steady phase, when it reaches a steady phase, the pressures can be very low. On the other hand, if you required lesser pressure to open it up, but the steady phase pressures could be slightly higher, which means that the opening pressure may not really predict what the flow would be like, or it may not predict the development of a hypertensive phase. I think a lot of patient-related factors are there in this particular hypertensive phase, I believe.
Last question, please. Intraoperative injection of steroids. Do you go ahead and do it to try to stop this phase?
I really don't do that, because in my opinion, I think steroids may be counterproductive, especially because while anti-inflammatory mechanism may be helpful, but steroid responsiveness is a huge problem that we have in our patients, and majority of our glaucomas are steroid responders. So I prefer not to give any injectable steroids. Of course, subconjunctival minimal dexamethasone of 0.1 ml is something that we give intraoperatively. So that's all. I don't give any long-acting steroids or long-acting steroids either in the supracapsular or the subcapsular area. Subconjunctival is what we give. It's a very short acting.
Thank you so much. Thank you so much, Doctor, for your